Let's talk about some tie-ins between the respiratory and circulatory system. So we'll talk about hypertension and edema, specifically transitate and exudate effusions, how these effusions can then also extend to the pleura. In addition, we have lymphatic effusions in the pleura, how deep vein thrombi can cause pulmonary embolisms. Then we'll talk a little bit about the nasal cavity, nosebleeds, and rhinosinusitis and things like that. So pulmonary hypertension can be defined as any sort of mean pulmonary arterial pressure greater than 25. So it's normally 14, systolic 24, 9 is diastole, leaning towards the diastolic side because that's about 2/3 of the entire contraction cycle. Ohm's law analog, the pressure in the pulmonary system is equal to the flow times the resistance. Well, the pressure is really just the pressure differential between the right ventricle and the left atrium. Well, the right ventricle is really just approximating the pulmonary artery. The left atrial pressure can be measured by the pulmonary capillary wedge pressure. So putting a catheter in the pulmonary vein gives us the pressure there, and that's really just the pressure of the left atrium. So we can rewrite this as, just substituting the RV for PA, knowing that LA can be determined again by the pulmonary capillary wedge pressure. Plugging in Puisseau's law and rearranging it, we get this nice equation. So this can show us that if you increase the left atrial pressure, you will cause pulmonary arterial hypertension. Well, that's probably the main way, right? The left atrial pressure builds up in left heart failure. Q goes up if I have increased cardiac output, and the radius will go down, which would increase the pulmonary arterial pressure. If I have any sort of hypoxemia, we talked about this, VQ mismatch, diffusion problems, shunts, things like that. BMPR2 is also a gene that normally inhibits vascular smooth muscle proliferation. So it's going to be associated with extra endothelium and less nitric oxide. So we have chronic vasoconstriction. This is just going to be a genetic predisposition to pulmonary hypertension. So left heart failure can lead to pulmonary hypertension, and then pulmonary hypertension can put too much stress on the right ventricle, which can lead to right heart failure, cor pulmonale. This is associated with ascites, hepatosplenomegaly, distended jugular veins, and peripheral edema. So the edema, though, that we're talking about in the lungs, not the lower extremity, but back to the pulmonary edema, cardiogenic. So if you had like heart failure, too much fluid means hydrostatic pressure is too large, or maybe you have cirrhosis or nephrotic system, so there's not enough proteins, not enough osmotic pressure. You're going to so this is normal, this is cardiogenic, and this is non-cardiogenic. So looking here, we're just going to push out water normally. Maybe a little bit of proteins, but mostly just water and fluids are going to get through. So I'm going to have a low protein content, less than 2.5 grams per deciliter. Now, we've talked about non-cardiogenic, things like pneumonia cause this ARD, cause this sepsis and malignancy. This is really very much just like your septic shock a little bit, right? So exudate is going to come out. So this is just increased capillary permeability. Proteins are going to get through. Fluid, of course, is going to get through. Leukocytes are going to get through, and the increased protein concentration is going to be somewhat diagnostic, greater than 2.9. It's going to be particularly cloudy, and because there's all of these proteins here, this runs the risk of infection here. So if you have an exudate effusion, it's got to be drained. There's something called Light's criteria for differentiating the transitate from the exudate. So effusion protein to serum protein ratio has to be greater than 0.5. So if it was cardiogenic, really just fluid would get through. So we can imagine that the ratio would be about 0 or 0.1, 0.2, pretty low. Now, if you have really leaky capillaries, it's never going to be greater than 1 because you're not going to push out more proteins than fluids. But you'll push out fluids and you'll push out some proteins. But still, even with leaky, fluid is more likely to get out than protein. So it's going to be probably between 0.5 and 1 if it's an effusion. Lactate dehydrogenase, this is usually associated with damaged cells, which is, so lactate dehydrogenase is in cells, the cells are damaged, the LDH spills out. Exudative processes are going to damage cells. So it makes sense that I should see these go hand in hand. A serum an effusion to serum ratio greater than 0.6 is diagnostic, or an effusion value that is greater than 2/3 of the upper limit of the laboratory reference range. And again, you can also just see the exudate is cloudy and the protein concentration is large, greater than 2.9. So these same effusions can also extend to the pleura, transitate, exudate, but also a lymphatic drainage known as a chylothorax, where something like the thoracic duct has been damaged and is spilling this milky, whitish, triglyceride-rich solution in that just builds up in the pleural space over time. So similar to cardiac tamponade, where you have filling of the pericardial sac, which presses on the heart, inhibits filling and inhibits contraction. Similarly, all of this buildup of pleural fluid can push on the lungs, can inhibit lung filling and expansion. If it gets too severe, it could even lead to atelectasis, so the lung collapse. But could also literally, cause cardiac tamponade to some extent. Here I have my heart in this mediastinum. If there's too much pressure, it could push into this and prevent the heart from filling and contracting. Pleural effusions are going to inflame the pericardium. This causes pleuritic chest pain, so pain upon inspiration, and it's going to be associated with a pericardial friction rub that can be heard upon auscultation. Gravity typically brings the pericardial effusions down. So this costophrenic angle is going to be completely blunted and abrogated. You can see it in axial MRI too, not to be confused with a pneumothorax, which should be radiotranslucent. This is radio-opaque. After treatment, we see that goes down, and that goes down as well. If somebody lays down, I suppose it could look, are they laying on their side, or are they laying on their back? It's going to affect how your, chest x-ray looks. Now, you need to drain this, especially if it's in the pleural space. So you're going to do thoracentesis. Make sure you go above the rib, because below the rib you have this neurovascular bundle, which you definitely don't want to damage. All right, switching gears a little bit to deep vein thrombosis and pulmonary emboli. So deep vein, so this is the deep veins, usually above the knee, and it's a thrombus. Thrombus is local, so this will have to become an embolus, which is going to exit the local area. Virchow's triad is something we talked about in hematology. So 3 things are going to predispose you to a clot: stasis of blood, hypercoagulable states, and endothelial damage. As an example, we can consider somebody after surgery. They're going to be bedridden, so that's stasis, check. They're going to have inflammation because of all the drugs and the damage to their body, check. And then there's lots of trauma, well, because they just had surgery, so check, lots of endothelial damage. Other risk factors will be things like birth control, pregnancy, and smoking, and obviously we're in the lung unit. These deep vein thrombi might, their first place that they might travel to cause damage is the lungs. So we can see the deep vein thrombosis here and see it a little bit there as well. So in the bottom part of the lung where the VQ ratio is lower, remember that the VQ ratio is lower. Yes, we have more ventilation because gravity pulls it down, but that has a much larger effect on gravity. So the overall ratio goes down. We're going to have more blood going there, which means we're going to have more clots going to the lower part of the lungs. Yes, the lungs have a dual blood supply, so they're somewhat resistant to ischemia, but nevertheless, there's 100,000 deaths per year due to pulmonary embolisms in the lung. So this can be defined as ventilation without perfusion. So if I have some perfusion, but my flow is 0 with a pulmonary embolism, so anything over 0 is effectively infinite. This is a VQ ratio of infinity. This is known as the dead space. This increases the AA gradient. This can be considered a type of obstructive shock. So we might see people with tachycardia and tachypnea. So this is going to be rapid onset pinpoint chest discomfort. So every deep breath or cough, pain is going to pierce the chest. This is known as pleurisy, where the pleura become inflamed and rub against each other, and this can be heard as a pleural friction rub. You can diagnose this with a D-dimer test, and you can treat it with heparin. So in about 20% of pulmonary emboli, you're going to see an S1Q3T3 ECG abnormality. That means that there's a prominent S wave in lead 1. So remember, it's a QRS. So it should go sort of like this, down a little bit, up a lot, and then maybe down a little bit like that. So this is let's take a look. That should be my Q. This whole thing should be sort of like the R, and this little thing here should be the S. Well, notice here we have a really pronounced S. Well, that's what we're talking about here with the S1. Q3 is going to be very prominent in lead 3. That's a lot more than this tiny little dip should be. And then the T wave is also going to be inverted. It should go the other way around for lead 3. So again, not everybody, but 20% of people. So that can be a useful diagnostic feature. There we go. All right, so the lungs can weather the storm, like we said. They have this dual blood supply. They're resistant to infarction, unless you have a really huge one, a saddle emboli, which sits right at the carina, which is where the two main stem bronchi are going to branch from one another. And you can see this on an axial MRI as well. Lines of Zahn, so these are formed in pre-mortem. So when someone's living and they get a clot, the high blood flow somehow causes kind of like rings on a tree stump. We're going to have platelet and fibrin red blood cells, platelet and fibrin red blood cells, platelet and fibrin red blood cells. So people get clots sometimes after they die, but they won't have these lines of Zahn. So that's why they're a useful diagnostic feature. Again, red blood cells, platelets, and fibrin. So lots of different types. It's not just, oh my gosh, Bill Paxton, you monster. So it's not, he's injecting somebody with a syringe filled with air to kill them. It's inducing an air emboli. More likely you're going to see this in a scuba case where you go down really quickly, you compress a bunch of nitrogen in your blood, and then it when you come up too quickly, it precipitates it, it's supersaturated, it comes out of solution and it forms air bubbles, which get into your brain. Fat emboli, if someone has liposuction or someone breaks one of their long bones, like the femur or something, fat can come out. This can get caught in the lungs, or even worse, it could go ahead and get past the lungs, get into the brain. Amniotic fluid emboli, during labor or a postpartum, amniotic fluid can break out and can form as a clot as well. Septic emboli, so heart valves and endocarditis, deep vein thrombosis can allow bacterial colonies to form, and these colonies can subsequently break off and become emboli themselves. Tumors as well can also become emboli. All right, let's kind of pivot and talk about the nasal cavity and sinusitis. So two types of nosebleeds, also known as epistaxis. Anterior nostril, which is where you break the Kieselbach's plexus. This is just a classic nosebleed, not a big deal. Posterior nostril, this is going to be the sphenopalatine artery, which comes off of the maxillary artery. This is very rare, but it's very life-threatening, and blood will go backwards down into the throat. So having a dry air can dry out the capillaries and make them susceptible to rupture. Picking your nose can honestly can induce endothelial damage, and obviously getting kicked in the face does not help. Nasal cavity is going to be lined with mucus. This mucus, is salts, and it sticks to bacteria and viruses, has lysosomes to degrade them, and then the mucociliary escalator can move them down your nasal cavity, down your pharynx, and down into your esophagus. Or, I guess you could spit it out, or pick your nose, or it can just go down into your stomach and be dissolved in the acid. Really, it's just a picture of what we just said. All right, sinusitis. So we have these really empty paranasal cavities. The frontal sinus above the eyes, in the forehead region, ethmoid sinus behind the eyes and the medial side, not to be confused with the sphenoid sinus behind the eyes on the lateral side, and then the maxillary sinus right below your your cheeks, right below your eyes. This is going to be the main one, and then the largest one. The point of these is just that air comes in, it circulates around your sinuses, and it warms it, it keeps it moist, it captures bacteria and viruses and whatnot, and can put them into the mucus and the mucociliary escalator. The mucus is, again, eventually moved down. All right, so the drainage of this mucus. We have a general picture here, but specifically, they're going to drain out of the sinuses through these little cavities called ostium. So here we have another picture of an ostium, another picture of the ostium of the maxillary sinus, and they're going to move back down your throat through your esophagus. We have these three, I'm not sure if it's concha or concha, these three concha, the superior, the middle, and the inferior. And here we have our ostium where the drainage is occurring. So The pathway in here is called the meatus, in between the concha. So the superior meatus is where the sphenoid and the posterior ethmoid is going to drain. The maxillary, frontal, and anterior ethmoid are going to drain in the middle meatus, and the nasolacrimal is going to drain into the inferior medius, shown here. So invading pathogens can cause an immune response. So it doesn't have to be pathogens. It could be infections, it could be environmental things or dust. It's going to cause your goblet cells to secrete more mucus as part of the inflammatory response. So this mucus buildup can cause facial pain, pressure, headaches, fever. So infections can precipitate this, but then pathogens can also thrive in the mucus that's generated. Changes in your voice and your sense of smell. So if air can't circulate, part of the reason that you sound the way you do is because not only does air coming in circulate in your sinuses, but air coming out can circulate in your sinus as well, and it can get clogged up if there's too much mucus everywhere. And it might be worse when you're lying down because it allows more mucus to come back into your sinuses. So a similar thing is aspirin-induced asthma. So remember that aspirin is going to inhibit COX, which means your more leukotrienes will be produced. And leukotrienes, for whatever reason, can cause hyperplasia of connective tissue in your nasal cavity. This can generate nasal polyps, which are completely benign, but nevertheless quite annoying outgrowths of inflamed tissue, shown here, and they can block normal mucus flow. So this can cause a mucus buildup. A deviated septum as well can be just as pesky, causing being a hindrance to mucus drainage. Note that the sphenoid sinus, if it gets a pathogen and mucus buildup, this infection could spread backwards into the cavernous sinus, which allows it access to the brain and into the meninges as well.